So with that, I will bring up Dr. Neda Amiri, who is a rheumatologist as well as a clinical associate professor at the University of British Columbia. Neda started a pregnancy and rheumatic diseases clinic, which I find amazing when we talk about different models of care and how we can better support people, which is the first of its kind. So with that, I'll just pass it right over to you, Neda, so we can hear all about it.
Thank you so much for having me, and thank you, Mary and Lori, for envisioning this program and bringing us all together. It's been so impactful and powerful to hear your stories. I've teared up already a couple of times. I see pregnant patients with rheumatic diseases every week. I run a full day of clinic doing this work, and I've been fortunate to work with Carl Laskin, Christina. I just took a screenshot, I hope that's okay, and shared that with Dr. Laskin, and he says hi. So I just wanted to let you know about that. And yeah, I was lucky to work with him, and I'm now lucky to work with Lori and Mary, and hopefully contribute to the research and the gaps in care and knowledge that you all have identified. And as you're all talking, I'm thinking of ideas and would love to connect with all and any of you in terms of, collecting resources for, as you mentioned, Christina, the journey doesn't end. And I think, having gone through 2 pregnancies myself, yeah, like I think everybody's like, okay, you're pregnant, like we're taking care of you, and then you deliver, it's like, bye, we'll see you in 6 weeks. And and that's those of us that are, supposedly healthy. I can hear my own echo. But yeah, even, not having a chronic autoimmune disease, like those first few months, that first year, it can, I found myself going to a dark place. So it's definitely something that us as healthcare providers, we need to do better work. Without further ado, maybe I'll talk a little bit about the clinic then, and the work that we've been doing. So we named the clinic, Predict. So, took a few letters from each of the words. Okay, let's see. I'm having also issues with it. Oh, okay, it's just slow. I established the clinic in 2017. I guess, going 7th, 8th year. We've been serving the province of British Columbia. So for people who live in the lower mainland, we've been mostly seeing them in person, but we get a lot of referrals from outside of the lower mainland, interior, northern health. So we have been able to offer them phone or even telemedicine visits. Obviously with COVID, we had to go virtual for part of that period. And I'll talk a little bit about the research actually even that came out of that. In terms of the referrals, so unfortunately patients can't do self-referrals. Most of my referrals come from other rheumatologists. So Christina, similar to what you had, the primary rheumatologist refers to me. But I also see a fair number of patients from obstetrician, obstetrical medicine doctors, maternal fetal medicine doctors, which are essentially obstetricians with further training in looking after quote unquote complicated pregnancies. In terms of the structure of the team, I'm the rheumatologist who runs the clinic. We're lucky to have nursing support through Mary Pack and the division. And our colleagues downstairs at Mary Pack are very helpful in terms of offering expedited support in terms of OT and PT, should we identify that the patient needs it. And we are also able to refer patients for a psych assessment through, again, the Mary Pack network. So this is deemed a quaternary clinic, and that means that it's not specialized, it's like sub-specialized, I guess. So we do have trainees who come to the clinic, and as you've all identified, this is a very niche area. So trying to spread the word. We have all our rheumatology trainees come through and they do 3 months with me. But we also have obstetrical medicine residents, again, obstetricians who come to the clinic, as well as internal medicine residents. And for those of you who live in BC, there's a new St. Paul's hospital coming, hopefully sometime in the next 5 to 10 years. And the vision is that hopefully we can expand the program and have an actual combined rheumatology obstetrical clinic. So stay tuned for that. We've had a lot of meetings, but we'll see where it goes. Okay, so I press the button. I'm going to be patient, see if it advances. One more time. Okay, one more time. Okay, there we go. So there are, the American College of Rheumatology, European League Against Rheumatism, and in 2019 they posted these guidelines in terms of, kind of as if you're a community rheumatologist, how you can work through patients with rheumatic diseases who's either pregnant or planning a pregnancy. It can be a little bit daunting if this is not something that you deal with, but as Christina also identified, a lot of these guidelines can be, I find, conservative, and I guess from a medical legal standpoint, it makes sense. So again, if you look at these guidelines, again, obviously you should not get on methotrexate, and if you get on methotrexate, it's like, okay, a therapeutic abortion is advised. But again, being a person who deals with this on weekly basis, I know that, yeah, if the patient who conceives on methotrexate, a miscarriage doesn't happen, the chances of having miscarriage past that 10-12 weeks, or having teratogenicity, or what we call birth defects, is actually very low. So, again, that's why it's important to have these individualized conversations with the patients. Okay. Every time I press the button, I have to hold my breath. So yeah, it can be a bit complicated. So in terms of how I approach the patient in front of me in the clinic, I've been trying to get our rheumatologist to refer the patients before they're pregnant. So, hopefully 1 or 2 years in advance of pregnancy. A bit of a joke we make is, even before your partner knows, maybe you can come and see us so we can have a conversation. So we take a thorough history in terms of, okay, when did you get diagnosed? What were your manifestations? What medications have you been on this point? When was the last time you took methotrexate, leflunomide, prednisone? Do you have any other conditions? Because obviously, God knows, you're allowed to have more than one. And then we do a medication review. Again, Christina, as you mentioned, does the patient have positive SSA antibodies? That changes how frequently we monitor the fetal heart rate. Are there antiphospholipid antibodies that may increase risk of miscarriage or birth complications such as preeclampsia and hypertension? And then there are all these other stuff that we also have to review as well. Are you up to date with your vaccinations, cancer screening? We know our patients with rheumatic diseases can be as higher rates of having cancers, and definitely patients with lupus at higher rates of having cervical cancer. Our patients take a lot of prednisone. This can reduce their bone strength. Are you taking enough calcium and vitamin D? So, sometimes it's just oh, it's just quick pregnancy consult, but it ends up being an hour and a half, 2-hour consultation talking about all these things. And then so we try to lay a roadmap in terms of, okay, this is what medication you're on. This is when you're thinking of pregnancy. Are you in a good disease state? Are you in remission? And what needs to happen for us to have a safe and uneventful pregnancies. We like pregnancies boring. And then once patients are pregnant, they come back. We typically do once per trimester follow-up for our uncomplicated patients. And then we do one postpartum visit. And typically at this time, the patients get discharged back to their primary rheumatologist. I was hoping maybe I can highlight a bit of research that's come out of the clinic. And again, this has been in collaboration with Mary and Neda and Amit. So this was a retrospective study that we did in the first 3 years of the clinic. So as you can see here, I don't know if you can see my cursor, from January 2017 to July 2020. So we saw 230 patients, and then out of these 230 patients, the first time they came to see me, 86 of them were already pregnant. So it was not a pre-pregnancy consultation. It was like, you're pregnant, okay, let's see what we need to do. And then about 140 of them were not pregnant. So it was an appropriate pre-pregnancy consultation. And in the follow-up period of those 140 patients, about a third of them went on to get pregnant. And you can see there are very few patients that I recommend against pregnancy. So again, out of these 144, only 14 of them I had recommended not pregnancy. And for most of these are not recommending pregnancy at this time. And then 40 of them had said, okay, yeah, you're good to go. Just to break down our demographics, the mean age of the patients were 33 years old. In Lower Mainland, you know, as you might know, there were predominance of Caucasian and Asian population, and a much lower percentage, as you mentioned, of African American patients. In terms of disease breakdown, sorry, I said African American, African Canadian patients. In terms of disease breakdown, lupus was the overwhelming presentation or diagnosis that we saw, followed by rheumatoid arthritis, connective tissue diseases, and ankylosing spondylitis. Thank you, Lori, for explanation. So what's the perk of having a pre-pregnancy consultation? Some might ask. Some of you have lived through it, so it might be a little bit kind of a duh moment, but it's nice to put it in numbers. So patients who actually got pre-pregnancy counseling, they were less likely to experience disease flares. And we know disease flares can be associated, obviously, with increased pain, increased rates of joint damage, but also in some studies, it's been a predictor of having adverse pregnancy outcomes. So I was pleased to see that. And they were less likely to have medication changes in pregnancy. This wasn't highlighted in this study, but we have other work coming up that shows that, you know, when we change medications in pregnancy, we cause anxiety. Because again, patients, again, some of you may have had this as a lived experience, but you know, every time there's a medication change, it's like, okay, is this medication safe for me? Am I going to have side effects with this medication? How is it going to affect my baby? And then lastly, patients who receive pre-pregnancy counseling, they were less likely to have disease flare in first trimester. In terms of pregnancy outcomes, so this is a table from our paper. On the top left corner, it's the pregnancy outcomes. So C-section, hemorrhage, spontaneous or therapeutic abortion, preeclampsia, and a bunch of neonatal outcomes. And then in terms of the headings, if I could orient you, patients without pre-pregnancy counseling, so 86 of them, and then patients with pre-pregnancy counseling. So overall, for the most of the outcomes, there was a trend towards fewer adverse pregnancy outcomes in the patient population that received counseling. But in this study, I think it was because of our low numbers, there was no statistical significance. Oh, sorry, too fast. And then this is another paper that we worked on with Mary and colleagues. So we looked at use and disuse or discontinuation of DMARDs, disease-modifying anti-rheumatic drugs in the clinic. So about 80% of our patients were on DMARDs before pregnancy, 60% of them during pregnancy, and 50% of them postpartum. I mean, when I initially looked at it, I was like, really? But when patients do good, I tell them to continue their medications, obviously, if they're compatible with pregnancy. But again, this is always a conversation that I have with the patient. And at the end of the day, it's their body and their choice. My job is to do the advice, do the reassuring, make sure that they have all the available information and they are ultimately in charge of making the decision. But even looking at some historical data, and I didn't include the original paper here, but Mary actually had done a study looking at health administrative database, and use of medications in those kind of older cohorts were much lower. So in the study that Mary had done, about only 7% of the patients ended up continuing the hydroxychloroquine. So while the number wasn't as high as I would have liked to see it, again, a higher proportion of our patients ended up continuing their medications. And specifically here, we're talking about hydroxychloroquine, sulfasalazine, azathioprine, and our targeted synthetic DMARDs or biologics. And then this was an important thing to highlight as well, and I try to drive this home, message home with my patients as well, is that discontinuation of DMARDs, and definitely abrupt discontinuation of DMARDs, can cause disease flares both in pregnancy and postpartum. So that's an important message. So now we're working on more prospective data. So we've dubbed our registry CAPRICE, Canadian Pregnancy and Rheumatic Diseases Registry. And we have now 2 sites. One is in Vancouver, one is in Hamilton. Always recruiting sites from across Canada. So if you or your rheumatologist is interested, please have them get in touch with us. So again, we're trying to capture patients in their first visit, and we invite them to follow them along their journey and look at both how their disease is, what medications they choose to continue, and how that affects the outcome of pregnancy and their infant. So the study's been kind of 2 years in the making, but I can maybe share a little bit with you. We looked at whether or not providing care in terms of virtual or in-person care matters, and the number's not big. We had 47 pregnant women, but in this instance so far, we have not found it makes a difference. So I think it's a bit reassuring to know that even if a patient is not able to see me in person, they can still be rest assured that they're getting the information they need. I guess the one caveat that we didn't talk about in this study is that most, if not all, of the patients who get referred to me and are seeing me virtually, they have a primary rheumatologist that's closer to them. So, if they do have a disease flare where they need to be, examined or have a joint injection or something, they do have access to their primary rheumatologist. But there are instances of patients that I'm the only rheumatologist they have. They live in like Castlegar or something, but I still try to manage the kind of healthcare system. So even if they're not able to come to Vancouver, they can get seen by someone locally. I think that's all I had time for. I went over time, so I apologize. Again, thank you everyone. And, if you've participated in any of this research, it adds up. It may not benefit you immediately in the moment, but it may benefit other women and our children. So thank you.
Yeah, no, thank you so much, Neda. And I would have, had I had the chance, definitely participated in your study, just because I would have loved to have known that whatever my information was, it would have gone to our better understanding, right, of pregnancy and the outcomes in our children at the end of the day. So thank you for that. There are a few questions, but like I put a little announcement in, so if we're all okay, I'll quickly pass it over to Vienna and Mary, but we'll try to address all those questions, but it might go just past the time that we had allocated, which brings us to beyond half past the hour, right, depending on your time zone. So I hope that's okay with everyone, including our panelists.